Thank you so
Yes.
much to Dr. Arora and to Dr. Sanjay for this invitation. I wish I had a mental health professional who uttered the words that Dr. Arora did in the beginning of the session 20 years ago. It's really, really heartening to see that at least the language and the aspiration and the politics and I would say that even though it's not stated, but I think the basis of such a guideline is the human rights of all of us. And that if that is forming the basis or if that's the aspiration of such a guideline, I think we are on a very good start. Thank you so much.
Thank you. I can see Dr. Yoga as well. Welcome. And any initial comments, Dr. Yoga, on the mental health, what the talks you have just heard?
Yeah. First of all, I would like to thank Dr. Sanjay, Dr. Kavita, and the entire team of ATHI. Actually, this conference was actually required. People are not aware. People are not completely, sensitized about the community. What community is? What are the mental health situation, what are the mental health challenges in the community, what community is facing. And I can see all experts, they shared their experiences, and it really helped me. Even all this talks actually helped me to understand many other things which I was not aware of. So thank you so much for inviting me as a panelist. Yeah.
Thank you, and you're welcome. So I think I'd like to start off with asking what your sort of thoughts are about whether the experience of being part of the LGBTQI community, or being able to recognize yourself as different as the society sees you, has that in itself, do you feel, does it make you more vulnerable to mental health difficulties?
I'll tell you, mental health challenges are everywhere, not only with the transgenders, but with all the genders. But why transgender is because transgenders are visible very clearly since childhood. Most of the time since childhood, they are visible, the way they talk, the way they present their, themselves, their body language. So all these things are visible. So the challenges, the teasing, all these things happen since childhood. So what I feel is it's like, it starts from family, then it goes to society, then it goes within the community. So when we talk about society, it is like you are stigmatized, and then eve teasing and all these things comes. And when it comes to family are like, you have your sister, you have your brothers, they are not able to step out just because of your behavior. There again, another mental health challenge comes. Then the community within itself, there are many transgenders who are into sex work, and there are many transgenders who are HIV positive. Many transgenders within the community itself, there are big, mental health issues. Like if you're a positive person, you're not supposed to stay with the community, or if you're staying with the community, you'll have to stay separate. Then the challenge come, like who will take her to the hospital, who will take care of her ART, if she's on bed, who will take care of her medicines and all these things. So challenges are everywhere. But I've divided into 3 points, vital points: society, family, and community. So challenges that the community is facing more, because we are visible, we are like when we walk from street, people know, I mean, like, this is a transgender person. So all these things comes up.
Thank you. Satya, would you wish to come in on this?
Yeah, I'm actually a bit disturbed with this conflation. And I think what kind of stood out for me quite early in the panel today, and it looked like it was something that, came from a framing of the issue where trans healthcare and LGBT healthcare are subsumed in a way that, we have been critiquing the government for subsuming intersex and trans issues in the same bill. Where enough delineation between the two, given that the history of the struggle around homosexuality and transness are absolutely different trajectories. I'm really wondering what led to this kind of a conflation, because it was almost like, and in all the panels, I would say, especially from mental health professionals from within the country, that they were alternating the vocabulary. Sometimes LGBT, sometimes trans, and from the panelists who have had experience abroad and are probably situated abroad, after a very, very long time, I must say that I had some very severe triggers, given that Dr. Vaidya has acknowledged that he is actually following ICD-11, that there was still usage of the word transsexual healthcare, and that from Jatin Parmar, that they were still following the model of real life experience as part of the diagnostic process. These are really archaic, I would say, archaic models now, as far as my understanding goes. And we would expect, I mean, I can understand that India is still from ICD-11 rolling out here in a major way that would constitute almost a regime change, because we need a regime change. If that, earlier I remember in Dr. Anwar's articulation earlier in the day, the way he expressed that this is not something that's going to happen in one training, this is not going to be something that can be expected of providers, just because that's a demand from a very consumerist language, I would say he was using, since we're also talking of language in this session of client. Even so, to acknowledge all of that, I thought, for me, starting from where you started, which was so affirmative, to the middle of the session, which was a mix of affirmation and unthought out collation and collapse of various gender sexuality categories, to ending with some kind of a very severe framing of like a pathologizing framing towards the end. And so my response to your question briefly is that this collation between, collapsing the trans, I would say, linguistically speaking, the category trans, I'm not going to say transsexual, I'm not going to say transgender, but the category trans as an automatic part of LGBT is extremely a problematic framing.
So continuing that conversation then, Satya, because I'm not certain that everybody in the audience would understand what you're saying explicitly, yeah? And I'm taking from how the talks have gone to say that, yeah? So policy, use of language, practice, and social narrative. I'm saying these are all separate. And oftentimes, what we say, what we mean, and what the other person understands may look very different. So I'm going to ask you to elaborate on that a little bit more with the lens of what you think in your practice could be a solution making in this regard. So we're saying here is a conference that is at least willing to look at putting things forward and accepting critique. Because such forums, we believe, need to exist. That's when actual practices and actual biases, which may be even internalized, even in professionals who are working in the field, will come out. That's our belief, that unless we speak, this cannot be highlighted. But now that we are speaking, I think one of my wishes or aspirations would be to learn from you to say 3 specific things that would have looked better to you. Because I really want that all the audience right now goes back with not just understanding what was problematic, but what each of us could do to change ourselves into something which is more affirmative. And that's the entire purpose of even taking out a guideline and accepting critique for it. Because someone somewhere has to start talking about it and then revise it and review it and come to a better place. So with that intent in mind, Satya, and even if you need a couple of minutes to answer that, I can, so we can come back to it, but it would really be helpful if you could actually say, yes, this was problematic, but besides the usage of the words, the intent behind it. What is it that was problematic and what is it we could do instead? So I'm leaving that question with you because I'd like to come back to it. And if you need a couple of minutes to sort of formulate your thoughts, I think I'm just going to lay out what Satya has said and brought out. And I think what Dr. Yoga has also said is that often what is seen by someone from a distance, and what is felt from within the community personally is very different. And therefore, the likelihood of miscommunication, especially if people who are making policies are people who have not had lived experience, the likelihood of not even having a bridge between the two is very high. And that is not helpful to anyone. So there is a line that the neurodiversity movement uses: nothing about us without us. And I think that's such a beautiful line. And I think that's one of the things that we need to make sure that the bridges, it's not about an expertise from either a mental health expert or a doctor or anyone else. This needs to be the collective wisdom of the community. And the only way change can happen is to actually collect the community. What do you think, Dr. Yoga, could be 3 things maybe or more that would be your ask if you went to a mental health professional? You've highlighted that many of the things which could look like mental health difficulties in the community are prevalent, either in the community, the family, society. Do you think if you went to a mental health professional to access any kind of help, what are the 2-3 obstacles in reality that you feel this won't work? And what are the 3 asks that you might want from them? And again, the hope is that in the audience, there are some of us who will learn from this.
See, it's we says that we have done, people know what transgender is, and many college students come for internship, and people know, college students know what transgender is, and they are interested to talk to them. They want to know the transgender. They want to make documentaries of the transgenders. All these things people are doing. We are doing a lot of things. Like, for example, couple of years back, maybe 10-12 years back, people were not aware about transgenders. It was like, when my brothers used to, when my cousin brothers and my cousin sisters used to look at the transgender, they used to get scared and they used to run. So first transgender who came to media and presented herself as a transgender, people came to know what transgender is. People came to know that transgenders also do masti, they also talk, they also dance. So she's Lakshmi when she came, on screen, and then people came to know what transgender is. And then slowly, many transgenders started coming, and they started presenting themselves, on screen. Then you can see now in media industry also, you have a lot of transgenders. Transgender want to do webinars, they want to do web series, they want to do short ad films. That is what we are doing, sensitization, networking, all these things we are doing. And we are doing this from last 12 to 15 years. But why it is not working out? Why things are not working out? What I feel is it should start from the childhood. That is, when we show a cartoon network, then why there is no transgender character in that? When you put a transgender character in that, kids will come to know what transgender is. Then they see Chhota Bheem, and when they see the other character, they know male, female, you have animals, why there's no transgender. So that is one thing. So now when we talk about the mental health professional, when we go and when we talk to them, so very first thing is like, I will go to a mental health person who is from my community, or who is very close to my community, who knows what community is, or whom I know personally. I will never take a chance going to a professional who is who don't know. I mean, like, I can see when I go to hospital, when when I go with my chelas to hospital, the way doctor look at them, the way they talk, the way they behave, it's very bad. I mean, even if they are good, their treatment is good, I may not feel like going and visiting them again, just because they're not smiling, they're scared, sometimes nurse don't want to inject. They're scared. So first thing is like, I would be happy if I go to a specialist who are known to me, who are from the community. If I'm getting a person from the community, I'll be very happy to go and get my things done. I feel the first thing, if a person is sensitized, he will definitely ask me, what are your problems? He'll sit with me, he'll talk to me, and he'll try to identify the solution. And he'll try to guide me in a very polite way. I have met many people like this in my life, where I went and they are like completely sensitized. They know what transgender is, and then when I go to them, they speak to me very nicely, very softly, very politely, and then I feel good. Then I feel like every time I should go there. I refer my friends, I refer my chelas to go and speak to them, because I'm getting very good, not only service, but the respect that I'm expecting. If not respect, then at least a support. Yes, we are there to support you. That one thing actually makes me go again.
Thank you. Thank you. So I would say respect and support is what is needed, and not but that's just, yeah. And I think that
there are people who are like, I also went to doctor who are like not really good. Unka medicine bahut really kaam bhi nahi karta hai, but the way they present themselves, the way they support us, the way they respect us, they give preference. Acha aap aaye ho, aap aa jaiye andar pehle. So even though the medicines are not good, we would like to go to him just because we get that mental peace, mental support, that yes, this guy is very supportive, even if he's not really a very good professional,
Sure.
but still I prefer to go to him just to get that happiness, that feel. Yeah.
And I completely acknowledge, I mean, even as a user, sometimes when I go to a doctor, one of the first things that I see is how I'm feeling in their presence.
Yeah.
And if I'm getting the respect, and if I'm feeling that I am a human being equal to them, that in itself is, I think, part of the problem solved. But I'm going to come back to Satya and ask whether Satya is ready to.
Yes.
Yes, please. Please.
Dr. Rora, I think I'm a bit hesitant to instrumentalize the discussion to a to-do list, to say like, give 3 things and give 4 things. I also feel that historically, the way the discourse is set up, both by us as different parts of the communities that we are part of, as well as other domains of social life that we engage with. Say, for example, the community needs to engage with the medical profession for various reasons. It could have been an engagement that we didn't need it, but we need it. Similarly, with the legal domain, etc. It is something that is brought upon you by the life that you develop these engagements. And then if you see world over, also we are experiencing a certain kind of backlash on trans rights. And one of the things that I feel is the reason why we are facing that backlash is because I think we ourselves have participated in a certain kind of a reductionist approach to the discourse. And I think this pressure also comes from the economic framing within which we seek services, which are mostly private setups, which are mostly profit-seeking setups. And it frames us medically in a certain way. It frames up medically within a certain language in a certain way. So the question of what would one say to a mental health professional, 3 things that one would say to a mental health professional. And I think maybe that is where I think the problem is to begin with, because we are reducing the entire dialogue to something that is what we are again and again being told by media is something that should be a chewable pellet by both who you want to communicate to, and also for other members of the community. And I think we are lapping this up very quickly and really not engaging with the question, especially historically. And this is something that you have also put out, that the historical trajectory is extremely important to continuously take into account. And I for me, in a way, if it was not to put it down in 3 points, then what would be my takeoff point? What would be my Archimedean point on this? And I would say that actually what has happened is that this entire engagement with, within quotes, LGBTQIA plus community, within quotes, trans genders, transsexual, trans communities, non-binary communities, etc., is the idea of difference. It just seems that that is central to setting up anything, setting up care systems, setting up a legal response, etc. But if we were to not only focus on the idea of difference, but if we were to look at a more essential category, which actually informs not only lives of trans people, not only lives of LGBT plus people, but I think also of cis people. And I hope you wouldn't contest from your own experience that many women that you would have known, even in your mental health practice, are extremely uncomfortable with their bodies. Many men who do not agree with ideas of a certain body type would also have similar experiences of life, which are embodied experiences, which comes from more symbolic categories of what is the right body. So I would say that for me, the starting point across LGBT, across trans, and across cis populations would be the idea of bodily integrity. That if that is where we begin, then I think we have enough of a component of difference and overlap that doesn't make the mental health provider the other. The mental health provider also is equally implicated in the formulation of, when I say I have bodily dysphoria, why do I have bodily dysphoria? I have bodily dysphoria not because it's a mental internal condition that I have. Like you are saying in the beginning of the mental health guideline, the problem is social. So in that social constructs the body and the mind of the mental health provider. That social constructs the body and the mind of a trans person. It's the same social, it's the same cis binary that is informing us, where you may be aligned to various degrees to that idea, and other people may be at the extreme ends of that, and therefore the experience of dysphoria. So in fact, I'm going to take your provocation, and I'm going to ask you a question, since you have said that questions are what you like and not answers, is to ask you the question, isn't the very diagnosis of gender incongruence, even though we have made a huge journey within mental health, from a very pathologizing framework to at least now now at least we're in a chapter that's not pathologizing, in a chapter that still needs the requirement of diagnostic codes, etc. But even then, do you think that this category, this naming, gender incongruence, is still a pathologization?
Yes.
So where do we begin?
Is that categorical enough?
Where do we begin?
Absolutely. I
Where
don't
do we
think
begin?
this.
I walk into your clinic,
Yeah.
and my diagnosis is still going to be gender incongruence.
Yeah. So I'll tell you, this has been my dilemma, and I'm going to share it with the audience as well. That my personal journey of understanding that this is not a pathology, and the journey of the current social and medical practices is at variance. Now, when I sit in my clinic, I'm faced with this dilemma every day. There are people walking in who, for their practicality and life experience, need that certificate. I can say, I do not think it's a pathology, and therefore I do not have the authority. I do not feel I am the expert. Therefore, I should not write this letter. Many of the people who approach me say, but then where do we go? Because there is no alternative practice except activism right now. So this is a dilemma, Satya, that I face every day. And what I have come, I'm not going to go into the entire struggle, but I'm going to tell you my one thing that I did, which I also arrived at over a period of time, is that with one young person like this, I sat down and I said, I don't want to sign such a certificate. And these are my reasons, because I do not feel this is actually my stance, and I do not feel this is the correct stance of the world, and therefore, why do we need it? So what we did was a co-creation. They wrote who they were, they signed it as the expert, and because my attestation was needed at the Gazette, I signed it, co-signed it with them. This was my simple thing, because they had said, it is our choice to change the gender in the Gazette. I need it. So for me, I go back to what your central tenet was. To me, the central tenet has become about the freedom of choice. In the current practices of society, does this individual have a choice? So I'm saying not from the point of view of aspirational only, I'm saying everyone has to live a practical life as well. If this person needs that certificate and wants to do it by choice, will I comply or will I not? So that's the practical aspect of what I do. Where I stand, I do not think gender congruence, I do not think sexual orientation, I do not think any of this is a pathology. I do not think it should lie in the medical space at all as a diagnosis. However, I'm also very aware that if we just say this is normal and therefore no additional problems exist due to the fact that society is not taking cognizance of the interface, then I'm also throwing the baby out with the bathwater. Because there are a lot of different people who don't have a voice, who don't have the articulation, who right now need part of that help, part of that support to get by with the practicality. And that's a choice I make every day. And all I feel is that the central part of this is the ability to make a choice. It's not my journey. It's the other person's journey when I'm sitting in front of them. And if I can keep my journey aside and co-create a solution for them in their journey, that's my stance as a mental health professional. That's my stance. And I don't bring in only my own stance and opinion every time. And that's a limitation, I feel, but that's where I'm at. Answered with as much honesty as the question that you've asked. But I do not feel gender incongruence, although it's been a journey, like you said. I do not think that we should even have it included in the ICD-10. I don't think that it is a medical classification of anything. I think every human, and I do not believe that this is true for only gender incongruence. I believe that there are other conditions that currently we are medicalizing, which are only a reflection of human diversity. There are certain kinds of wiring, for example, and I bring in my child mental health bits, learning disabilities that have been seen as disorders for an immense period of time. I believe they are socially constructed. These are just a part of natural diversity. We are naming them as disorders. I think these are artificial guidelines. These are artificial components and compartments that we have made. But may I say, that's my personal opinion. I'm still practicing, and there are many, many young people that I diagnose with learning disabilities. So, and that's the constant dilemma or dharam sankat of a professional in a period of transition where history and the future looks very different. Historical perspectives are very different. We are in this phase where they have to meet. And I think it's a dilemma for it's an everyday dilemma. I don't know if that answers your question satisfactorily, but again, it's an opinion. I also am aware that Dr. Jatin wants to respond to your remarks.
I would also like to come in a little bit on what you've said, but I'm going to hold on that and have Dr. Jatin listen to him. Yes.
Dr. Parmar, if you're there, and would you like to? Yes.
Yeah, thank you for that. Yeah, I just wanted to clarify what Satya said earlier on about my comments about real life experience. It is unfortunate. This is historically looking at it as well, where that why are mental health professionals actually firstly involved in all this then? So historically, if you have to sort of look at it historically, the way it has progressed and real life experience, and I think the problem with all that sort of thing has been that in the past, even getting into a diagnosis was quite difficult, at least in the Western world. You were expected to sort of almost be living as as you wanted to be before you could actually get any treatment. Those sort of things have now passed, at least from the point of view of a diagnostic sort of thing. And I know that you're discussing the morals and ethics about sort of whether this should be placed in diagnosis or not. And I think I would also direct you to the new just about imminent, I think in the next few days, is WPATH conference, because one of the first things that they're going to be discussing is gatekeeping. And I think the aspect of whether, and I think I would say that you've mirrored a lot of my sentiments in one sense as well, Dr. Arora, in the sense that how do professionals exist in this space where people do not want to be pathologized, but inadvertently do end up being pathologized because of the construct of sort of how medicine is delivered, if you want to call it, and as you mentioned, that is the answer whether you take it out of the ICD-11 or whatever, and then how is that regulated? Because the other aspect of all this is prevention of harm as well, and I think that's one of the sort of central tenets for medicine as well, that people do not undergo any harm as well. So there's an aspect of discussing that. But just sort of on the specific point of Satya saying that it was a real life experience for diagnosis, that's not the case in the UK, and I think my understanding of the US system as well. But unfortunately, when it starts coming to gatekeeping around surgery and stuff like that, there is an aspect of an expectation of that happening still, and that is probably the leftovers from the historical perspective around this. And I think that will probably be changing in the future as well. But the concepts of harm and prevention of harm, I think, still provide some sort of responsibility on the professional to sort of, evidence their sort of actions. So, you need to sort of show why you're doing something. And I think that's where I think I place myself somewhere to say, this is the reason why I'm going to give this person, this hormone, which may sort of potentially cause them harm as well. Actually, I mean, it is obviously going to be for their benefit, and I'm ensuring that I take care of all the safeguards that are required, but sure, that this person needs to be informed about why I'm going to give them this.
Sure.
Yes, they want it, but they need to know why that's being given as well.
Yeah. Thank you, Dr. Parmar. I think it highlights what we started off with, that the problem is social and in the social structures. So the dilemma that you face, or I face, or many of the mental health professionals also face, is a social structure problem. This is how delivery of services has been structured. And either we conform or we don't. So I think, again, it brings us back to the dilemma: who is responsible for changing these structures? Who or what could drive the change in these structures? So I think I'm coming back repeatedly to the circular notion of who's accountable, because the impact is on the individual and family. There's no question about that. But the accountability is nebulous. So I think that's the unfairness and inequity that I feel all the time. And I'm wondering whether that's something, Satya, you would like to comment on?
Yeah, I think what I would like to table at this point is that I think a lot of trans activists who have been looking at the specific constituents of this dilemma in terms of from the point of view of trans persons who are asking for specific things, specific interventions, and from the point of view of providers who are also struggling with, and I don't want to sort of understand Dr. Jatin Parmar's idea of harm as only something that is socially constructed. There is, of course, a large component of it that is socially constructed, but in terms of actual medical constraints that the human body is dealing with, and there are certain limitations that providers will have to seriously look into. And say, for example, one of the things that has been coming up quite frequently in the recent past is say, for example, we do not have, say, for example, it's something extremely small, but one understands how critical it can be in healthcare and in terms of the actual bodily constraints, is that we don't have ranges for path reports for trans people. What we have as normal ranges are ranges available for what is understood in the binary of men and women when we go for standard path tests. Now, these are things that are also things that are already out there in the discussion, that these are things that have to be formulated. These are things that have to be standardized. So I think there is no running away, Dr. Parmar, from that aspect of the interface, where providers have, again, I would say, legal responsibility as laid down within the legal regimes of their countries that they are operating in, and that has a real life impact on them. As well as on the end of the trans people whose own bodily functioning will also can also have certain constraints within which desires can be met. So there are limitations of all kinds that are operating on this moment. But to sort of say that if one resolution could be what Dr. Arora is suggesting, is in the clinical practice of that case on case engagement of how to go beyond this point. That's one. And I'm wondering whether, the time is now really ripe for medical practice and human rights to start talking to each other more seriously in terms of creating this framework of healthcare provision that protects both the trans person and the provider. It's not trans person. I think right till now we have been going, the trans community is attacking the doctors, and doctors are like, hey, we have all these. I remember in 2011 when we had our first meeting of some activists around the globe, where for the first time the idea that we should start lobbying with the WHO to start shifting the codes out from the specific chapter that it was in ICD-10 to now these were exactly the responses we got from within the trans community, who were coming from different parts of the globe, saying, hey, we need it for insurance. Hey, we need it for legal gender recognition. If you do not give us this diagnosis, my life will stop, because I won't be able to have the gender marker on my educational certificate that I need in order to do the next degree. If you don't give me this certificate, I won't be able to seek medical insurance. These are very real life things. And I'm not saying that that is to be lost, but I'm saying that we cannot make this the constraint of the caregiving. This is there in the caregiving. But I think we have to start co-thinking about larger frameworks that have a history, that have the capacity for institutionalization, that have mechanisms of accountability on both sides. Is what I feel the moment is right now.
Absolutely. So the collective is absolutely. So I'm going to try and bring the discussion back a little bit more towards mental health as well. And one of the things that I did want to ask, especially Dr. Yoga, was the talk of across the age span. I think often we talk more about the young people, and we talk about the age group, 20s and 30s. But what are some of the difficulties or some of the issues or some of the comments that you might have where we are talking about as we progress through the age? Dr. Yoga, I think you're on mute. Yeah, okay.
So you must have noticed, that now the more young people are coming out with their identity. More people are like, earlier it was like when I was child, I used to get scared to, come and, tell to my teacher that, I feel different, I'm different, and to my parents also, if I tell my parents that when I was in 5th, 6th standard, and I was very scared to come and, talk to my parents. This is what I'm feeling. This is how I am, my choice is different, the way I look at the society, the way society look at me is different. So, because we used to get scared, okay, if I say something, if we, tell this to our parents or teachers, they may hammer us, they may shout at us, why do you feel like this, we know you're not different, for all the parents, the child is same. If I biologically, if I'm born like a boy, then for my mom, I'm always a boy, even if I do all surgeries and all medical things. For my parents, we are like kids. You're born like a boy. I call you as boy only. So that is one thing which and I really like that, because my my dad used to say, if you have a child who is handicapped, we will never kick him out of your house. You will never kick your handicapped child out of your house. After all, it's our child. So it's the same way you are also. If you are a different, if you are a different gender, then we have no issues. This is what my parents used to say. So in a study, it has been identified that due to this, as I said, more youngsters, more teenagers are coming out with their identity. They're ready to come and tell, see, we are different, we are transgender, so we are gays, we are lesbians. Now, earlier it never used to be, till the time you don't go to guru, you don't become a chela, and then you don't follow that transgender parampara, you never used to come out, never used to dare to come out in society. But now people are coming out, people are more qualified, more sensitization is done, colleges are accepting transgenders and inviting transgenders to come and conduct a session on gender. But again, the stigma still exists. The stigma is still there, the problem is still there, which is forcing in a village. I have an example to share. In a village in Kerala, the parents identified the child as a transgender. So they came to know the way the body language is different, the way he speaks is different, the way he presents himself is different. So what they have done is, like, when he was like 17-year-old, parents decided to parents started forcing him for marriage. So that was the saddest part. Somebody told the parents that after marriage he'll be fine, and that was the saddest thing. Then this guy, through some other community member, he went to some community guru, and then that community guru took her to the police station. Then this police station called child psychiatrist, and then the counseling was done and everything was done, and then finally it came out. Then there was like lot of things, parents has to go under parents counseling, then the family counseling, then the child itself, because he was minor, then he has to go under counseling. So all these things happened. It has also been observed in one survey that 31% of the 31% of the community members commit suicide. The reason behind that is either isolation. They have been isolated just because of their gender identity. And in the 31%, 50% of the community members are below 20 years. So I will share the link, where I've read this. So this is very sad part. So more and more sensitization, more and more networking. It is not with the community members. It's not with the school teachers, it is not with the nurse or medical practitioners. It should start from the family. It is very important for the family to accept the child the way it is, the way the person is, because unless and until you don't get the support from the family, you won't be able to do anything. So I have a strong, earlier it used to be, children, the youngsters used to get scared when you look at the trans person. Now people are more open. People know what trans person is. People, college students come, they visit my organization. They want to do internship. They want to know what transgender is, what basti is, what badai is, what toli is, what are the type of sex workers involved. So sensitization, my guru always used to say, sensitization bahut ho gaya. Now it's time to work on field. So it's time to, make yourself a role model and, be a part of the entire journey, be a first brick, and you present yourself in such a way that, people, your community member itself will start following you, that if she can do it, I can do it. So that is something which I feel.
Yeah. Thank you for sharing that, and thank you for sharing the journey as well. I'll take a question to Satya, and then I think in a few minutes we are also going to be hard pressed for time. But I would like to ask Satya, do you have any comments about the age span question, the question of not just talking about when we come out, but the journey thereafter. Sorry, you're on mute, Satya. You might have to unmute yourself.
Yeah.
Yes.
Can I request you to say the question again, please? The question is?
So I think we often talk more about the journey of coming out and the problems people face in the beginning. But what is not often talked about is the travails of, as you grow, the needs of a person who is in their third decade, fourth decade, fifth decade, start looking different in humanity. But we don't often talk about what happens and what goes on in those times. And do you have any comments or any? Yeah.
I also think, Dr. Roy, it's also a matter of, because I think identities, this is my own understanding, identities are essentialized by human processes. They are in themselves, especially social identities like being a man, being a woman, etc. And then once certain identities come into being, then history around those identities come into being. So say, for example, if somebody was to say that, you know, this gay person in 300 BC, that would be historically wrong. We know that, right? And if we were to say for us, why is it that we do not talk of certain ages, like let's say post-transition, if that is the journey that you have made, and you are in your 50s, you are in your 60s, what's really going on with you, what are your trans healthcare requirements, what are your mental health requirements, etc., etc. It's also, I think, because as a population, we have come onto ourselves just now. We're coming onto ourselves just now. And as it happens with many populations, especially whose identities are coming into being just now, the cross-generational aspect of that population is still in process. I remember I think 2 months ago, we had a webinar amongst trans-masculine people, where I think for the first time in my lived life of 48 years, somebody who was 48, like me, was meeting somebody who was in their early 20s. In my lifetime, when I was beginning my transition, I never met another transmasculine person. And I remember my psychiatrist, my process was done at AIIMS, Delhi. And my psychiatrist, when I asked him, this was 1996. I asked him if there was somebody who had done this that I'm thinking of doing. I don't know what it is. I don't know what are the repercussions of going along this route. How will I look if I start HRT? Can I meet somebody? And he said that he's going to check on with some 2-3 people that who were coming to him. He would check with them and he would let me know. And when he came back, he said that these people have refused to meet, and they have said that they have dealt with this problem in their lives and they have gone back to society, and that they don't want to open up this problematic chapter again. And I think so this identity formation, which I understand as historical, this population coming onto itself and therefore having a certain kind of critical mass in terms of policy, critical mass in terms of, maybe allocations in gender budgeting, a critical mass in terms of reservation across education, basically dealing with the nation state. This population to come onto itself as that critical mass of numbers in order to be able to have an engagement with the nation state can only then start thinking cross-generationally. And I think once our generation, which I think is the first really within quotes out generation, in another 10, 15 years, I think you will start looking at programs for elderly trans masculine people. I'm sure it's going to happen.
Well, I'm into that. And I do agree that we should move with the times and grow with the times. But I think that's how often change comes. It's led by certain people so that the rollover and the effect can be felt by the next generation and the next decade, and the advantage of it is then felt by the So thank you very much for participating. I'm going to ask for closing remarks, anything that you feel that you have not talked about and that you would like to talk about, anything that you feel you'd like to say to the audience, that you feel is pressing. And I'll go with Dr. Yoga first.
So thank you once again for giving this opportunity. My last point that I would like to share, that's a request. Unless and until you don't accept the community, it is very difficult for others to understand. If one friend is accepting the community, looking at him, the other will also accept. So it is, if you will say no, the person is not good, then it is very, your friend will follow the same. There is a peer group, which follows. I think Dr. Sharma will agree with me. So there is this peer group which, follow. If one person is smoking, the other will follow. If one person is going for night out, the other will follow. So that is one thing which I feel, I have a request. I was conducting a session with 𝗤𝗏𝗍𝗁, and then when I entered the room, the conference hall, people were scared. In fact, the principal also was like not completely satisfied, sensitized, and he was a bit scared to come and talk to me directly. Then I went, and then when I started talking, when I started sharing my experience, my journey, and the way the parents accepted me, my friends accepted me, and the way what I'm giving to the society, my education, my experience as a social worker, as a performing artist. When I opened myself, people came to know more about me. People people understood that it is not we all are same. It is just that chromosome XXXY, nothing more than that. It's it's everybody is same. So respect not the gender, but the skill that you have. Give more importance to your skills, the way you talk, the person, the way the human being is.
Thank you. That's so valuable. Not just look at the difference, but also look at the similarity, this universal humanness and the human dignity of being. Thank you so much, Dr. Yoga. I've been told we have 10 extra minutes, so I might come back to you and not consider that as a closing remark. But Satya, is there something that you might like to say to the audience?
I don't know to the audience so much because I think I'm not very clear what who the audience is in terms of, is it mostly mental health professionals or is it also the communities
Yeah. So there are people from the community, there are people from the college, Jamia Hamdard. So there are students there as well, and there are mental health professionals. There are some parents who have joined as well. So it's a mixed bag, and because this is also on Facebook Live, right, the audience could be far wider than who's there in this. Right. So I meant the general society, and it would be valuable to hear for posterity.
Right. Since Dr. Arora, I would sort of I would want to make a very specific comment actually, because this is about, and it's been inaugurated on a guideline that has been conceived and written out. I was wondering whether we could undertake some kind of a formal mechanism to bring the document also to the communities and have their participation in a collaborative way. In addition to it being authored by mental health experts at the moment, because I think that contribution could be really, really useful, especially when we are also acknowledging the whole idea of knowledge production and where it comes from and who it belongs to and who it serves, etc. That is one thing that was in my mind to share. And the second thing I was wondering was, also, I think this is something that requires a little bit of thinking through, because when we say Indian standards of care, in a sense, it requires various qualifying features to be able to say that it is Indian in the sense what? Why do we need Indian standards of care? Why would, let's say, even though we know that, let's say, WPATH standards of care historically are based on the US experience, what is it unique about our experience of gender, about our social living, that will inform the ethos of such a document? Are we able to embed this document with that, and what that might be? I think that's a discussion, I think, and at the same time, it evokes the universality that a document like this needs to evoke, is something I think we should be able to engage with, is the second point that was in my mind.
Sure, and I think those are very valuable points. We've had several discussions, Dr. Sanjay and some of the other core group members. I think we are talking more about the mental health section, but I think you're spot on in saying both the points. One, the question around why a particular section for the Indian standards of care, are they any different? What are they located in? What's the context of it being Indian? The second question that I had put forward is, are they standards of care? Do people have to account for them? Are they merely aspirational guidelines as of now? Because we are not a regulatory authority. We are not part of an institute which is a regulatory authority yet. So those are both questions. And the third question that you've asked is lived experience and sort of collecting. So yes, that has been sought in many of the other sections. We have many of the people from the community as well. And we hope that we run even the mental health section through and with the help of many other people, including yourself, Satya, if you are, I'm taking that as an offer to help with it.
Absolutely,
so,
absolutely. As we have already discussed, but within the constraints of everything else, of course,
absolutely,
as well.
Absolutely. Yes. So we'll keep working on the document, of course, and it's not an endpoint in itself. I think it's a dynamic document as of now. So absolutely, all those points taken. I'm going to invite Dr. Sanjay to speak about why we talked about an Indian standards of care, because I think he's the right person to, I mean, I have my own view and I've talked to him often about it, but I think he's right here and he should talk about it for a few minutes.
Thank you so much, Dr. Kavita. It's such a pleasure. In fact, it's a dream come true. And there's so much learning that we are ready to do. And learning is needed. So why Indian? And the first thing that I will honestly share is because I needed it. It is I, as a parent, who needed a narrative that is fitting into my world. Because, and I've said this earlier, that the way we were educated, the way we interacted with professionals, they gave us narratives which were not from my place. I, for one, believe in care. I, for one, believe in healing. And I know, coming from a family of healers, that healing really does not require hospitals, it doesn't require drugs, it doesn't require too much of infrastructure. What it requires is a person who will care. And we know that this healing starts in the family. So I resonate with what Dr. Yoga says, that the family, if the family is comfortable, then the being that they brought into the world is going to be comfortable. But then why is it not so? It's not so because they are scared. And why are they scared? Because the society scares them. And what is their fear? Their fear is not for themselves. It is for this very being that they are bringing into the world. So hence, Satya, it has to be Indian. And that is my demand as a parent, as a family unit. And family unit is the first building brick of society. I also want to get this narrative further and talk about it to society in large and say, stop looking outwards. Let's start looking inwards. Let us reconnect with what we knew to be correct. When I ran into my mother's lap, she never distinguished between, what was between my legs, so to say. Sorry for being crude. But it was me as a being that was comfortable. But the moment I did those things which would hurt me or which my parents perceived would hurt me, I would get a smack. And I come from that generation where we were smacked a lot. Today, people don't do that. I myself am a proponent of that this is not needed. But then it was out of fear. If we are to address this fear, this dysphoria, which promotes that dysphoria, then we require the Indian standards of care. And when we talk about Indian, it is this Indian sub-culture. When I visited the Sun Temple and I saw such vivid descriptions there, and the guide was talking to me more sense than any mental health professional would do. And he says, no, you take a round like this, and this is life. This is what a person is expected to do in life. This is what they do at this time of the day. This is what they do at this time of the evening. This is for pleasure. This is for procreation, and this is for socializing. And what essentially that person told me was that if we are able to celebrate this and put it up in our temples, then definitely, and I'm very firm on that definitely it cannot be wrong. Yes, we probably have lost connect. And that is the connect that we need back in our lives. We need that family understanding. And we need, for the family to be comfortable, I need to be able to talk to my parents. I need to be able to talk to my chachas, tayas, buas, and all those very important people who teach me so many things in life. I cannot for a moment comprehend how a document which is produced across the seas, which comes from people where family structure is very different from mine. Why would they be able to understand what I'm going through? This is the question that I have. And throughout my training as a doctor, I have been told, that question needs to be answered. Because if you have answered that question to me, if you have made me comfortable, then I can make my child comfortable, and that is why it has to be Indian. Yes, this document, when we got along on the journey of putting it together, and we had this issue that who are you to do it? I said, I'm the parent. I am that atom of this structure. I am that first brick with which the society is made. So I am qualified. How will you do it? I will find more bricks, I will put them together. It may not be the most beautiful structure that will come up. It may not be perfect, but then at least I will have a shelter. I will then plaster it. I will then, get other people who know more than me. And mind you, I will share over here on this platform with the entire world listening. I took my time passing my MBBS. And my colleagues, they did much better than me. They know so much more than me. But they were not able to answer this one question. That how do I make my child comfortable? And if they were not able to answer, then I need to find that answer. And the answer is here with me, that yes, I want that Indian standard of care and I will create it. And that is why I chose to be a not-for-profit organization. I chose not to associate with any government. I went out and I sought people who would help me make the structure. I presented it. I set the seed last year. I have been building on it. I won't say brick by brick because bricks are big things. I will say atom by atom. Today, when I am invited to give my comments on a mental health platform, I'm elated. Me being asked to give my views means that somebody has started listening. And if that is happening, then for me, that is qualification enough. I will take this forward. I will continue learning. I will invite people to please come, tell us. Yes, I don't know. But if you don't tell me, then how will I know? So I kept a separate session on 2nd, and I said, anybody who asks me stuff that I don't know, I'm going to tell them, please come 7 p.m. tomorrow. I shall be there on the Zoom platform. I shall give you a voice and a mic, so to say, and please explain to me, answer my question, and let us take this forward. I hope I have summarized why Indian, and that is what
sure. And I think your passion shows through as well, Dr. Sanjay. So thank you for that. I think a couple of things that I'm going to add to what Dr. Sanjay said. One was the fact that we wanted to also come across something that was relatable and not just take from the context of the West. We also felt that there were certain parts of Indian culture that possibly would be baffling to someone reading the WBATH guidelines, and vice versa. What I mean is that if we are saying, for example, that the problem itself is social in the mental health section, then the social problem in itself, it doesn't take away from the fact that even in the West, the problem might be social. But certainly the social structure in India is different often in terms of the family and the way the family image is held, or the individualization in sometimes the Western countries, or some of them, versus the sense of community or the sense of carrying your image for your community. So if from my surname, my entire family is known. From the fact that I am not getting married to a boy, my entire family has to suffer. It is not just mine to own. And we felt that there were so many cultural practices and social practices that were so different that to actually locate these guidelines in a relatable way for anyone who was an individual in the Indian society, we might have to do it slightly differently. So the second concept that I think I was very vociferous about was that we cannot say we are treating the person. It's just not okay, because then we are defining the problem wrongly, and therefore the solution cannot take from there. And what I do find even in the WPATH guidelines is that while there are references, and many such references to discrimination and the kind of social roles and all of that is played, the central tenet is about treating the person even today. And I think that's the part that I know I spoke to Dr. Sanjay and said, I'm not going to write a guideline which says that, because I can't do it and I don't agree with it. So either you find someone else or you go with the way that I'm talking about. So I think for me, what was important was to base it from where we were, what our laws said, because all these, Satya, like you said, the interfaces that are thrust upon a person who is different. the need to navigate the medical world, the need to navigate the legal world. These are not necessarily things that are universal. Section 377, 2018. That's not true of the West. That history is not true of the West. But are Vedas having people with gender variation? That's not part of the Western culture either. So I think somewhere the attempt needs to be to say, whatever we know over here and whatever is practical over here, should we start from there? Definitely take from whatever else is going on, learn from it. But do we also need to start from where we are and make it relatable to the person who's reading them? And at least the mental health section, the aim is not for only professionals to read it. The aim is that the mental health section, if picked up by any person who is an ordinary citizen who wishes to do something and be an ally, or at least understand a little bit more, should find a space or a few pages that they can read. So that's really the intent. We'll see how it progresses, I guess. We'll see with time how the journey unfolds. And we hope that it will be fruitful. And we hope for many revisions, even though I'm saying that myself. We hope that there will be so many revisions that more and more people will add to it and modify it. So that's where we are. And I will request that we end the panel. I have had a beautiful and enriching experience with the diversity, and I think that's absolutely wonderful. I think it was not just about the guidelines, it was about so much else and so much about the lived experience as well. I'm going away enriched. So I'd like to thank Team ATHI. I'd like to thank Satya and Dr. Yoga especially. I'd like to thank all the speakers and the audience and all those who participated. Thank you for making it an experience that is of human dignity and equity.
Thank you.
Dr. Yoga, you wanted to say something?
I once again would like to thank the entire team. And, before the session, I had a talk with Sanjay sir, and he told me, about the session, because I was like, I just came from outstation, and, it was very difficult for me to go through all the chats. So I just called him. Then I spoke to Dr. Kavita. They also helped me. So thank you so much, everyone, the team of ATHI and all the panelists. Thank you.